I think we are going to just start kicking it off. So I'm really excited to have you all here. Hello, my name is Sarah Jones. I'm the CEO of PMD Alliance, and you are in for a treat because you are going to get to hear from one of the most amazing physician partners that we have. He has extensive expertise in movement disorders and actually oversees the dementia and cognitive center at Georgetown. He is really passionate about serving people with Parkinson's and looking at ways to do that in a very human-centric way. And I think that's one of the favorite pieces that I really enjoy about him. It's also a piece that you'll get to learn from him as you think about your practice. As I look at this and I look at the different people that I saw registered, so that you know we have people from physicians to social workers to nurses. So we really have actually kind of a really nice variety of people that are on this call right now who are going to be listening to you, Dr. Torres-Yagi. This is the first of two programs that we're going to be doing. I'm excited about this one, which we're going to kick it off with. And the second program I'm really excited about because it's also talking about how do you do clinical assessments and do effective assessments even if you're doing them remotely. And he will be able to share not only expertise about that, but his clinical experience and how to make that work, because that's one of the things we don't want to miss for people just because we can't see them in person. So I'm not going to take a lot of the time because I really want you to be able to talk, and feel free to put questions in the chat box if you have questions. This is being recorded, so you'll be able to watch this later over and over for all of the stuff that you're going to want to go back and watch, because I know what, having heard from Dr. Torres-Yagi before, you are going to get a wealth of information. So thank you so much, Dr. Torres-Yagi, for doing this, and many thanks to Acadia for kind of spurring this for us. So I'm going to turn this over to you now.
Thank you, Sarah. That's such a nice introduction. I know Sarah and I have done presentations before, and there's music playing sometimes. Sarah hums in the background Jeopardy music sometimes when we need it. And but that's when we would do some polls sometimes. So there's no.
I can always hum if you need me to. You just let me know.
If I start getting delayed because of technical difficulties, we might need it.
I'll hum.
Okay, perfect. Well, thank you so much. I have a slide presentation to address the title, as Sarah mentioned. We are going to be discussing advancing Parkinson's disease changes. And you can see there, that is me. I am a professor working my way up to associate professor at Georgetown. I head up the Parkinsonism and Dementia Clinic. And we're going to talk a lot about Parkinson's disease. So please, I want everyone to feel energetic and motivated to ask questions. I want this to be educational, but also engaging. So please feel free to put questions in the chat box, and I can answer questions as I go. And I know because we have people that are listening that are in the field taking care of these patients, this is a pretty high level educational session. And so we're going to talk about Parkinson's disease and what happens. And it's going to be beyond the motor symptoms. It's not all motor. We're going to talk about non-motor, but you're going to learn about the actual progression of symptoms and how things advance, just like the title says. So first things first, the UK Brain Bank criteria is what we use technically to diagnose Parkinson's. Okay, so we look potentially for step one is bradykinesia, which means slowness of movement. Now this can trick us because out there in diagnosis land, there are plenty of people that their job is to diagnose a patient with Parkinson's disease. That's their job. They're either a general practitioner or they're part of the internal medicine office in an area where there might not be a big academic center. There might be a neurologist there that's not a movement disorder specialist. Sarah's heard me tell my joke that it takes 34 years, including preschool, to become At least it took me 34 years, including preschool, to become a movement and memory disorder specialist. Some people do it faster, but I had to do 2 years of other stuff because I didn't make my mind up in undergrad about what I wanted to do. So I took 2 years where I did other odd jobs. And then I said, all right, I'm going into neurology. Let's do it. So, but until then, it takes 2 years to do a fellowship. And so if you go into a community practice or any practice and you don't have a tremor, a lot of the times that makes it more tricky to diagnose Parkinson's, because many people think Parkinson's is just a tremor disorder. But in reality, you don't need to have a tremor to diagnose Parkinson's. And so you need slowness of movement, right? And if you think about people that are 60 or older or over, there might be it might not be uncommon to have slowness of movement. That's bradykinesia. But if you have slowness of movement with rigidity or a tremor that's present at rest or gait impairment or postural instability, if you use that, that's the UK Brain Bank criteria for diagnosis of Parkinson's. Now, we can stage Parkinson's disease. There are 5 stages in terms of how Parkinson's disease advances. We usually say that stage 1 in Hone and Yar, that's called the staging, is unilateral, one side. Stage 2, kind of self-explanatory, it's on both sides. Stage 3 means there's some impaired gait. Stage 4 is that you need assistance to walk. And stage 5 means that it's hard to walk even with assistance. So you're either in a wheelchair or it's harder even to get you into a wheelchair. Now, this is a fun slide that I use in my teaching. I'm an academic neurologist, as I mentioned, and we think about Parkinson's disease as an alpha-synucleinopathy. That's a lot of syllables, right? Alpha-synuclein is hard to say, but it's a protein that builds up in the neurons that leads to essentially a neuron that has too much of this protein, and so it becomes dysfunctional. And the dopaminergic neurons, the ones that predominantly release dopamine, can be affected in the substantia nigra. And they develop what are called these Lewy bodies you see on the top right of the screen. And that's just protein accumulation, which is basically showing you that the neurons that are supposed to produce dopamine are affected. They have this protein accumulation, and then it leads to reduced uptake, a reduced release of dopamine. The way we find it is with a neuroimaging biomarker. So if we see a patient that might be slowly moving with gait impairment and we suspect Parkinson's, there's an actual nuclear medicine scan that can be ordered that if you see over here on the left, so bottom right though, but there's two pictures. On the left of that, it says DAT scan normal, meaning it's an unaffected brain. On the right, you see an affected brain. If you see, rather than 2 comma-shaped structures in the basal ganglia, the part of the brain that's affected in Parkinson's, if you, rather than see 2 comma-shaped structures, you see 2 periods, that usually indicates a dopamine deficiency like a Parkinson's disease. Now, we're talking a lot about brain, right? Brain is all real estate. So if you think about, where you are in the brain, you can have a part of the brain that's affected where you have dysfunctional neurons. If it's in one part of the brain, you might diagnose Alzheimer's, right? If it's in another part of the brain, you might diagnose Parkinson's disease, right? And so it's really all about what part of the brain's affected leads to the clinical symptoms. In Parkinson's disease, tremors, rigidity, slowness of movement, gait impairment, it's all a function of low dopamine levels, okay, in that midbrain that leads to reduced uptake of dopamine in the basal ganglia, the caudate and putamen. So that's the basal ganglia is the part of the brain that helps refine movement. And here you see the substantia nigra neurons. On the top, in the middle, you'll see in the midbrain, you see this dark substance. That's what substantia nigra means, because dopamine neurons are dark. And so what you see here in a Parkinson's disease brain is that you don't have that dark staining, that substantia nigra. So you have dopamine loss. Now, we're talking about how Parkinson's disease advances, right? So we talked about Hone and Yar stages or staging of Parkinson's disease. It's very much about how that alpha-synuclein works its way up into the neurons. So before it hits the substantia nigra in the midbrain, there are symptoms that occur due to this protein accumulation within the brainstem. So you might have symptoms like loss of sense of smell, trouble with sleep and wakefulness, low blood pressure, constipation, anxiety, and depression. Where's the Parkinson's disease diagnosis, right? We're not even there yet. This can happen decades before we have substantia nigra. Really, the substantia nigra is very much affected. And so this is a graph that reflects time. And so I want to focus just for now on the pre-symptomatic and early non-motor phase. You see those two arrows? There's 3 arrows on the x-axis. Pre-symptomatic means, okay, we don't know, there's no symptoms just yet, but we might have dopamine neurons are starting to become affected. And over time, you're going to see those neurons, the remaining neurons, go down, 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 down. And as those remaining neurons go down, the non-motor symptoms come up. You see that orangey colored graph? So the lower the amount of neurons that produce dopamine, the higher the amount of sleep disorder, lack of sense of smell, depression, anxiety, constipation, orthostasis. Orthostasis means the blood pressure drops when it's not supposed to. Now, Parkinson's disease we mentioned is a disorder that has to do with movement. But also now I've mentioned not all movement, right? We said lack of sense of smell, constipation, depression, anxiety, sleep dysfunction. It's not all what you see, right? It's a lot about what people feel. But if you look at the graph down here, there are 3 time points that we really look at, right? The first time point is early in the disease course, then middle in the disease course, and then more advanced disease course. And what we tend to see is that as the disease progresses, the medicines that we use, carbidopa, levodopa, over time become less effective to provide stability. And that's because of multiple factors. But the concept is, if you lose the dopamine producing neurons and you lose what's called the buffering capacity of those neurons, the medicine carbidopa, levodopa that's taken sometimes 3 to 6 times a day or even more sometimes, it might not last as long. Each dose administration is meant to last maybe 6 hours early on in the disease course, but as the disease progresses, that medicine becomes less and less effective. Now, what do we do to treat the motor fluctuations that happen? So you might see in the moderate to later stages, a patient after they take their medicine, they might become wiggly. That's called dyskinesia. Or they might wear off of their medicine at 2 to 3 hours rather than it lasting 6 hours until their next dose. They might become frozen and their symptoms might return. Those are called off periods, as you see on the left. There's a bunch of things that we do to avoid that. We can try increasing the dose of levodopa, changing the formulation to an extended release formulation, adding medicines, taking medicines at night if someone wakes up in the middle of the night. Protein reduces absorption of levodopa. There's surgical treatment modalities like pumps and deep brain stimulation that can be helpful. There's treatments that can acutely help with wearing off. Dyskinesias are the wiggliness that happen at that peak dose effect. You can use medicines that combat dyskinesias, like amantadine formulations. Think about surgical options. These are the surgical options that we have. We have deep brain stimulation. We have a carbidopa levodopa infusion pump that goes through a PEG jejunal tube. And this is in clinical trials right now in the United States, but it's available in Europe. It's a subcutaneous dopamine agonist apicin infusion pump. You see there, it doesn't go through the gut through a PEG tube into the jejunum. It goes into the skin. And so it's we liken it to an insulin pump like for diabetes. Now, let's focus our attention rather than the pre-symptomatic and early non-motor phase. Let's focus our attention on what happens later, right? As we lose more and more neurons, we might see more and more motor symptoms continue to develop, and the non-motor symptoms can get worse over time. And so it becomes more and more important for us to focus on how it is that we're going to treat more advancing disease. And let's dive into that a little bit more. So we talked about anosmia or hyposmia, which means lack of sense of smell. Constipation can develop and get worse over time. Depression, anxiety can get worse and worse as the disease progresses. There's something called REM behavioral sleep disorder, which means patients of ours can act out their dreams as the condition progresses. Remember, Parkinson's disease, I've said a lot about dopamine, and it's the dopaminergic function, but it's not all dopamine. It can be norepinephrine, serotonin, acetylcholine. Those letters, those acronyms mean it's not all about one chemical. Multiple chemicals are low in the body of a Parkinson's patient that can lead to symptoms. This is the Brock hypothesis that talks about the advancing symptoms. And what I show you here, again, is kind of similar to what we talked about already, but I want to reinforce the concept that Parkinson's disease may in fact start in the autonomic nervous system of the GI tract. Again, might start in the gut based on the Brock hypothesis. And it works its way up. You see over here on the x-axis, you're seeing that left thing that looks, that's a GI tract. That dark thing that almost looks like a sausage is actually, that's your gut. And what they're showing you is that your gut can be affected 4 to 15 years before you even have tremors or rigidity. Then we see a nose, right? Hyposmia or anosmia can develop. This is a heart as we move down that x-axis. The nervous system of the heart, the nerves can be affected with alpha-synuclein. And then we start having things like drops in blood pressure, arrhythmias. It's hard to control our vasculature. That can lead to lightheadedness. Easily, patients can feel like they're going to pass out or become lightheaded. Then this is a patient sleeping or a person sleeping. As we work our way up from the gut, up the vagus nerve, around the heart, then into the brainstem of the brain, as you see here in the darker red colors, that's the brainstem. That's the sleep and wake center of the brain. That can be affected, and we can have our patients act out their dreams. They can have sleep fragmentation. It's hard to stay asleep. They can wake up and they don't know why. It's hard to turn in bed. And that can all those symptoms can predate the Parkinson's symptoms. Those are called the non-motor symptoms. This is another way of thinking about it, of looking at the fact that Parkinson's disease, even though I'm a neurologist, I have to be a psychiatrist, I have to be a gastroenterologist, I have to be a urologist, I have to be a dermatologist, sometimes a pulmonologist. All of these organ systems, the nerves are part of our whole body, right? So if your nervous system is affected, all of these organ systems can be affected too, okay? And so that's kind of the bottom line here about what it is that I mean when I say that Parkinson's disease, as it advances, this is what we're looking for. I told you about the Hone and Yahr stages, that you start with one stage, but it's not all about what the movement symptoms that the patients are having. Look at this, neuropsychiatric and cognitive dysfunction. I told you I'm the director of the Parkinsonism and Dementia Clinic. Depression can be seen in 40 to 70% of patients. Anxiety, psychosis, dementia, cognitive impairment. 28 to 78% of patients may develop some form of mild cognitive impairment. And it's been shown that close to 20% of patients at disease, when they're first diagnosed, might have some sort of cognitive impairment. Fatigue, apathy, sleep disturbance, constipation, look on the right, urinary dysfunction, sexual dysfunction, drooling. And then what about sensory? Pain. Who would have thought, if you don't really dive into Parkinson's disease analysis, that our patients might be suffering from pain, vision changes, trouble reading. There was a very important study that was called the Priamo study, and it was done, now we're getting to about 11 years, I think. And what we're seeing, or 12 years now, what we did, well, what the study did was look at multiple centers in Italy. And they looked at a high number of patients and they wanted to see what it was, how many patients had these non-motor symptoms, right? And what they saw was 98.6% of patients had at least one non-motor symptom, right? The 12 domains: GI, pain, urinary, cardiovascular, sleep, fatigue, apathy, attention, memory, skin, psychiatric, respiratory, miscellaneous, or sexual function. All of these things were present. One of these things were present in 98% of these patients. And the average Hone and Yar was 2. So these were patients that were not very advanced in terms of the progression of Parkinson's disease. So what we saw here was, on average, fatigue was seen in 58% of patients, anxiety was seen in 56%, leg pain, 38% of patients, insomnia. Look at this, look at all these things, sialorrhea, which is drooling, urinating at night. Look, 31% had difficulty concentrating, okay? Now, this is another way of looking at the way Parkinson's disease advances. And what we're showing you here is, let's get to year 0, that's diagnosis. Now, we've kind of walked through the minus 20 years, minus 10 years, we say constipation, REM behavioral sleep disorder, hyposmia, depression, sexual dysfunction potentially. Year 0 is hopefully the year that we diagnose a patient. After that, that's when we see tremors, rigidity, everything like that. Now, look at MCI. MCI is between 0 and 10 years. MCI is not the phone company, or the old phone company. Remember MCI? MCI is mild cognitive impairment. And you can see that as the disease progresses, we have those motor fluctuations, like we said. We might have more urinary symptoms, more orthostatic hypotension. That mild cognitive impairment might develop into dementia. But what about those last more advanced cases? Psychosis can be part and parcel to Parkinson's, especially in advanced stages. Let's go over some. In order to present today, I actually looked at the most recent guidelines for some of the non-motor symptoms. So this is a lot of information, okay? But this is the Movement Disorder Society guidelines on all the medicines that we can use to treat mood, right? Didn't I say anxiety and depression are part of Parkinson's? Actually, they might predate Parkinson's, but then they can get worse as the disease progresses. You can use our medicines, our dopamine agonists, to help with mood. You can use monoamine oxidase inhibitors to help with mood. But if you see here, based on the strict guidelines, even monoamine oxidase inhibitors like rasagiline or selegiline, there's not true sufficient evidence to actually recommend them. But we use them in clinical practice for movements, and they might help with mood. Tricyclic antidepressants are likely efficacious. We tend to use selective serotonin reuptake inhibitors like citalopram, sertraline, fluoxetine, venlafaxine is one. Here you see that actually is deemed efficacious and clinically useful by the MDS as of their most updated guidelines. There are other antidepressants that can be used. There are some more, I think, investigational studies using transcranial magnetic stimulation, which is used in refractory depression. Cognitive behavioral therapy, of course. We just hired a social worker in our practice, and it was very helpful to have her because she actually is able to help us with therapy. I can't tell you, I told her, all of our patients need you. She said, so where do I start? I said, just start, open your clinic, and you will have a very, very, very active social work clinic. From start to finish, there is so much need for a social worker in all neurodegenerative diseases, but in particular for my field of movement disorders and memory loss. Social work is just, I mean, without my social worker, now that I have one finally, after this is my 4th year in practice, I've been thinking, what have I been doing? It's like I've been walking with one leg. You know, I need 2 legs to walk, and I only have 1 leg to help my patients. So let's think now other non-motor symptoms. I know there's a lot here, but orthostatic hypotension, the point is we do have a medicine that's efficacious and possibly useful. It's called droxidopa. There are other medicines that we use for orthostatic hypotension, but droxidopa is one. Sexual dysfunction, sildenafil, is something that we do prescribe. I didn't say we do put on our urology hat at times, and we do use medicines to help with sexual dysfunction. Constipation, things like prebiotics, efficacious, clinically useful. Abdominal massages. It's not all pharmacologic, right? Might be insufficient evidence, but since it's non-pharmacologic, things like that can make a difference. What about drooling? So we use botulinum toxin. Botulinum toxin B is a type of therapy we inject into the parotid submandibular glands. Botulinum toxin A is also efficacious, more recently been approved for sialorrhea. We talked about neurogenic orthostatic hypotension, but in general, all of our patients need hydration, right? We said that the heart is affected, and as the condition progresses, we have more heart impairment. And so we tend to screen for orthostatic hypotension. We might do what's called an autonomic nervous system tilt table test to make sure. We screen for lower extremity edema. We screen for lightheadedness upon standing, because norepinephrine, we said, is adrenaline. It helps stabilize blood pressure, and that's also lacking in our patient population. Hydration, liberalizing salt intake. We talked about droxidopa, but there are other cardiac medications that we use for orthostatic hypotension. Now, my favorite topic is memory and cognition. In addition to what we've talked about, Sarah Jones knows that we pride ourselves in being a blended movement and memory disorders. We have our thinking hat on. We try our best to think about all the things that we can do to help, but we use medicines like rivastigmine, donepezil, memantine for cognitive impairment and dementia. Rivastigmine is a patch. It's very helpful. And then what we see here for dementia and cognitive impairment in Parkinson's disease, if we see the way things advance in Parkinson's disease, donepezil and rivastigmine are acetylcholinesterase inhibitors, and they're very, very helpful in helping promote acetylcholine as the disease progresses to help stabilize people's cognition. Now, what about psychosis? I told you, I'm going to go back quickly. I told you, if you look at the advancing Parkinson's, this is how Parkinson's disease advances. Psychosis, you see here, anywhere between 0 to 10 years might start. And what you see is, as psychosis gets worse and worse, also things are getting worse from a motor standpoint. The non-motor symptoms are getting worse. And so I'm going to bring us back. My point here is, if you look, psychosis can be seen in all neurodegenerative diseases. But if you look at Parkinson's disease dementia, we see that maybe in about 50% of cases, we can see hallucinations or delusions, right? And so that's because our brain relies on not just dopamine, but dopamine, acetylcholine, serotonin, norepinephrine. I know I've talked about this a lot, but serotonin also plays a role. And so psychosis might also be due to not just the fact that we use medicines that promote dopamine. Dopamine can cause psychosis, right? The medicines that we use can worsen or enhance or cause psychosis, but also we get this upregulation of serotonin receptors as the disease progresses. And so medicines that might target serotonin receptors might be helpful. We tend to try and use medicines that are antipsychotics to treat psychosis, such as quetiapine, clozapine. With clozapine, the hard part is that you need to do regular blood testing to make sure, because there's a side effect of aplastic anemia that can happen. And then if you look at the treatments for psychosis, what you see here is that quetiapine is possibly useful. Clozapine is clinically useful, but you have to do specialized monitoring. Actually, it's weekly blood draws for starting someone on clozapine. And pimavanserin is a medicine that's approved for Parkinson's disease psychosis that's both efficacious and clinically useful. And based on safety by the MDS, it's an acceptable risk without specialized monitoring. And so treatments for depression and sleep, we talked about the antidepressants, SSRIs, SNRIs. We use benzodiazepines or melatonin for people that have REM behavioral sleep disorder. And mirtazapine can be helpful in patients that maybe have depression or difficulty sleeping. Trazodone can also be helpful for depression and difficulty sleeping. And that is the end of my presentation. And I hope that everyone enjoyed it. And I hope it was helpful. We had this wonderful pictorial through the slide deck, but I'm now here so that I can answer any questions. What do you think, Sarah? Was it a good run through of advanced?
I think it was fantastic. It was fantastic. And I see Alyssa nodding her head. And as a social worker, I'm sure she appreciated as an MSW, I'm sure she appreciated the comments about social workers. We can't agree with you more. Way underutilized, I think, in movement disorder centers and neurology practices. And you were just adding social worker to your many different hats that you were wearing until you got one. So that's exciting.
And just like it takes 34 years to become a movement disorder specialist, it takes a long time. I can't just wear that hat and think that I know what I'm doing, a social work hat. It's a field that takes time to get there. It's almost like, sorry, I'm going to get off topic, Sarah. Is that okay?
It's okay. No, it's right. Go ahead.
So I live in Washington, D.C., and I still remember it used to take taxi drivers, and I'm telling you, years to get a taxi driver license. Years. And they would learn the map. This is all before, we had our phones and before GPS and everything. They had to know every street of Washington, D.C., which is one of the hardest cities, I think, in the United States to learn, because there's no logic to it. It was just kind of a bunch of circles and roads. And I still remember when Uber first started, it was like the taxi drivers were so upset. They said, I can't believe it. Our whole field, people are trying to do what we've been training for years. That's what I feel like sometimes when I used to try and do social work. I felt like I was driving, but I didn't know where I was going. I was using GPS, but I really didn't have the right intuition of what street to turn on. That's what it felt like. Now we have a social worker, and you can really see, I mean, the sigh of relief that our patients have now that we have one. I mean, it's incredible how much help that they can help us with, especially as the condition progresses, when the non-motor symptoms become more and more pronounced and our medicines become less and less effective. Advanced care planning, deciding about advanced directives, just living situations, cognitive behavioral therapy, everything that has to do with resources and support become even more important than our medications that we can offer.
I actually think that was a wonderful analogy, and you're right. I mean, I think it's one of those fields that people think, yeah, we can do that, but it is absolutely a level of expertise, and just knowing how to navigate these systems that are out there and to pull together these systems is just, that's huge. So I'm thrilled. I'm really glad you shared that. And that's something that I think we could continue to share with our healthcare professionals, like people that are on today, because it's going to save physicians burnout and also time, so that you can spend time with your patients doing the things that you're trained on. That, that's a win-win. And we have a ton of questions. So I'm going to do my very best. If I miss your question, you're just going to have to put it in there again. But I'm going to track it. I'm pretty good at this. One question is going back to that nuclear medicine scan. So I think you talked about the DAT scan. The question was, how accurate is that if a patient actually gets that?
Great question. So, should I bring up the slide again? You think, Sarah?
Sure.
It back up for a moment. Let me just show you. Okay, I'm sorry for, so you don't get dizzy. You can close your eyes. Let's see. All right, so here you can see, so this is the DAT scan, and so just to bring it back, so does everyone have this capability? Not everywhere, right? So you really need a big nuclear medicine department, or a radiology a site that has multiple things aside from MRI. So nuclear medicine isn't everywhere. But so you see, this is a DAT scan. It's actually looking at the caudate and putamen, the basal ganglia, the part of the brain that relies on dopamine. And so what you're looking at with the DAT scan are receptors that respond to dopamine. So what we're looking at on the left, if you look, so the DAT scan that's unaffected, you see the caudate and putamen form that comma-shaped structure. In an abnormal scan or a dopamine deficient brain, what you'll see is rather than those comma-shaped structures, you'll see period-like structures. Now, it's not uncommon for the scan to read as normal, but the symptoms to be there. And we call that symptoms without evidence of dopamine deficiency. That's called SWED. It's not uncommon for us as a clinician, we order the scan is read as not Parkinson's or not dopamine deficiency. And we still treat the patient, we don't treat the scan. So we say, look, most likely what we're dealing with is a SWED case. You look like you're slow in your movements. You look like you have a little bit of a rest tremor. Let's give you medicine potentially for Parkinson's and see if we're just picking this up very early. So it's possible that early on in the course of the disease that the scan is in fact, you have a false negative scan. But we still do our best as highly trained subspecialists to treat the patient as a symptom without evidence of dopamine deficiency.
Oh, excellent.
Another issue is if the scan, so what's used in determining whether the region of interest on the scan is in fact positive or negative is a software system that looks at a normal, it's basically a bell curve. And it's possible that we see a slight loss of comma-shaped structure. So if, for example, if on the right comma, there's a little bit less of a tail in comparison to the left comma, and the symptoms on the left body, which correspond with reduced uptake on the right, remember everything's crossed in the brain. If we see, even though it's within the range of normal, but there's some asymmetry, we might say, look, it's read as normal, but in fact, knowing your clinical case, it's actually, it's consistent with what we see. And so that can happen too, where we kind of, we're more critical of the DAT scan, even though it's within range of normal. I'm sorry to cut you off, Sarah.
No, that was wonderful. That's actually very helpful. And I feel like one of the things you just emphasized, and because I know we do have some social workers and nurses on with us today, this is one of those times where I would just kind of underscore in bold the importance of making sure that a person sees a movement disorder specialist. Because, you know, you talk about that subspecialty, that neurologist with advanced training in movement disorders. And I wonder if you could just say a few words in case that's kind of new for some people.
Right. So, okay, you got it. So movement disorders is a field that it's relatively, you know, new. It probably developed, you know, in the 70s and 80s. The people who actually created a subspecialty within neurology, they're still practicing. And so the people who coined the term are still practicing movement disorders. And so it's really evolved into a subspecialty field in the past 2 decades, truly. And in the past decade, it's become even more and more subspecialized. All the fields of neurology have become more and more subspecialized as therapeutics continue to advance and advance. We are seeing a therapeutic explosion in some subspecialties of neurology: stroke, multiple sclerosis, movement disorders. And so you got it. It really does, in many cases, it's good for a patient who might have or is thinking about, you know, potential symptoms and needs a diagnosis to also make sure that they see a movement disorder specialist, because so much has changed just in the past 10 years that, you know, if you were trained as a general neurologist and you weren't in the field of movement disorders close to research or close to training, so much has changed that a lot of the times, you know, if you see a doctor that's just a general neurologist, they might be good at treating Parkinson's disease, but as things advance, Or in tricky cases where it's hard to diagnose, we might be missing diagnoses. And so these are important things. If I have I give a story about my aunt who we diagnosed with Parkinson's disease. She lived in South Florida, and she actually saw two doctors who misdiagnosed her or didn't diagnose her with Parkinson's. And she ended up seeing me when I was a resident, and my mentor at the time, who's still my mentor, who's a movement disorder specialist, and we diagnosed her. And so that kind of tells you that there's a difference in terms of the diagnostic capabilities and therapeutic capabilities.
Yeah, thank you for sharing that. I just think it's really important. And we'll put a link in the chat too for people if you have, there was a question about how do I find one to help with my patients to make sure that my patients have that. So we'll put that in the chat too. So there was a question about the dyskinesia. This person has a patient with a lot of dyskinesia. They say it doesn't hurt them, but I suspect it impacts their socialization. Do you have any thoughts on that?
Good question, and very high level question as well. So there is a difference. There's a distinction between troublesome and non-troublesome dyskinesias. And so if you look over here on the graph, so as the disease advances, you might see more and more motor fluctuations, because that window, that white, you see there's blue, there's white on the y-axis, and there's green. The white window is the therapeutic window where people feel good. They're not dyskinetic. They're not under-medicated. They're not wearing off of their medicine. So what can happen is people can become dyskinetic in order to feel good. That nice whole white where you feel like you feel whole and you feel not dyskinetic, you don't feel off, that window becomes narrower and narrower. And so as the disease progresses, sometimes people need to be dyskinetic in order to not feel off of their medicines. And so that's what you start seeing, is that stability, that ability to stay within that therapeutic window, you lose it. And so if the patient is either doesn't have insight, it's possible that some patients don't have insight into the dyskinesia, or they know they have it, but it doesn't bother them, it's not painful. Or if they have it, it's not affecting their dexterity or walking, okay? Then a patient might feel like the dyskinesias are okay to live with. They can tolerate them. Those are called non-troublesome dyskinesias. Now, if you feel pain, or you're falling, or you're dropping things, or you can't control your dexterity, that becomes a troublesome dyskinesia. But the bottom line is, if someone's experiencing dyskinesia, it's important to dive in and understand how many hours a day a person's dyskinetic. Are they also experiencing wearing off? How frequently are they taking their medicines? Are they using all the medicines that we have to be able to address the motor fluctuations? And if so, if we've tried to optimally manage their case, if they are experiencing motor fluctuations, that's a good time to really start teaching them, or at least talking about advanced therapeutics, adjunctive therapies, and maybe surgical treatment modalities. So does it make sense? Because once we've reached that threshold, it's about disease progression, right? As the disease progresses, motor fluctuations will continue.
Excellent. Thank you. And it's almost like you knew you were going to tee off the next question, which isn't necessarily a surgical piece, but somebody asked about, what about focused ultrasound as a treatment?
Right. So we have to, it's still being studied. It is there. We have patients that have been interested in it. But we're learning more and more about it. Focused ultrasound is a treatment possibility. We're learning more about it in terms of Parkinson's disease. We do know, I think, a lot about it in terms of essential tremor. But the focused ultrasound, I would say the short answer to that is that we have to learn more about it. And we have to continue to follow the data that come out from the clinical studies using it. The things that focused ultrasound does is essentially target the part of the brain that's affected, that we mentioned in Parkinson's disease and in essential tremor. But we need to understand not just the short-term effects of focused ultrasound, but the long-term effects as well. And so we'll continue to learn more about that as these years progress. I look forward to more and more publications about focused ultrasound.
And what role, if any, or how it would play a part in the Parkinson's piece. That's great. So I'm going to combine a few because there's I think they kind of go nicely together, because there's questions about like the smell issues, there's questions about reflux and GERD, and there's questions about microphagia, and all of these kind of as early symptoms potentially. So if I combined them, I would say when you're looking at those kind of things as early symptoms for people, how do you decipher, what might be tied to Parkinson's and what might be another issue?
Right. That's a great question. These are great. I was told never to say that every question is a great question, but what can you do when they're all great? So seriously. So, I mean, I think that's true. I actually I did a patient symposium, and a patient came up to me and was like, you can't say every question is a great question, because then what do you mean? Then that doesn't make sense. It's like giving everyone an A, but it's true. So it's hard to know. Sometimes there are some things that are called non-specific findings, right? Non-specific findings can happen in many, many conditions, right? Fatigue. I mean, how many people I'm fatigued, right? It's Friday, we're all fatigued, right? So if someone came in and say, I have fatigue, are we going to go down the road of, wait, could there be Parkinson's? It's really, you're looking at a combination of things. So I'll give you an example. So if someone is 40 and has I haven't talked about restless leg syndrome. Restless leg syndrome can be part of Parkinson's, right? Restless leg syndrome has been acting out their dreams for several years, lost their sense of smell. Maybe they're walking and their arm swing on one side is not as much as on the other side. They might have some depression, some anxiety. If we put it all together, sometimes we might follow those patients, over time and say, wait, hold on. So you have constipation, some restless leg. I just added constipation too, right? You have these combinations of things. Let's keep an eye and make sure, that we're tracking and we're making sure that you don't develop symptoms of Parkinson's. Now, that's not something that we tend to do unless we find a combination of symptoms. If someone just has constipation, right? Then that's something that a GI doctor, because it's a non-specific finding, that constipation can be caused by multiple things, right? Depression and anxiety, that's true too. A lot of the times, what we notice is that it's not until later, where you have symptoms of Parkinson's, where we ask about patients' history, about their past, and we screen for non-motor symptoms, and we say, have you been constipated throughout your whole life? And they go, yeah, actually, I've been constipated since I was in my 30s. Or do you act out your dreams? Yeah, my husband or wife tells me that I talk in my sleep, and I've more recently started punching, kicking, jumping out of bed. Those are the things that we tend to hear. And it's almost in retrospect that we're using those to kind of help inform us and raise our diagnostic, certainty in cases where it might not be as straightforward.
Excellent. Okay, that's great. This is such a good chart too, and I think it's good for people to know. I love the focus that you have on non-motor symptoms. You and I talk about that a lot, that they're really the most challenging part of the disease process for people. So anytime any practitioner and provider can become aware of watching out for those and creating the importance of assessing those and treating those, I think is great. Somebody sent me a private message tied to, the question was tied to antipsychotics for people with Parkinson's. This person shared that they had a patient who went to the emergency room and was given haloperidol. And I'm wondering about maybe just kind of sharing again the antipsychotic medication.
Yeah. So if you look, so these are based on the guidelines as of 2019 for movement disorders. So there's a wonderful paper, you see the reference there, that talks about everything. It's a really wonderful run through. And so this is essentially, when you're a doctor or a PA or a nurse practitioner or, advanced care provider, and you're treating patients, you have to make certain decisions, and not, it's not always that people know, about the concern about, not necessarily using, the atypical antipsychotics or typical antipsychotics in patients with Parkinson's, right? Something as simple as a urinary tract infection sometimes can create psychosis, periodic temporary psychosis, and our patients might end up in the hospital for UTI treatment, but now they're out of their element. They might have some cognitive impairment, maybe the propensity to hit that psychosis threshold, but if they're not infected with a UTI, they might not have psychosis, right? And that's where we see our patients run into trouble, because the team that's trying to help them not be psychotic is giving them medicines that are blocking receptors of dopamine and can be harmful. And we know already that antipsychotic use, in the elderly, based on multiple clinical studies, in dementia and in Parkinson's disease, you have to make sure that you're using the right ones. But if you look here, what we're showing you is that if you look at efficacy, safety, and practice implications, okay, let's go through. So for clozapine is efficacious. It's an acceptable risk, but there's specialized monitoring. We said you have to check your blood. It's a very involved process to ask a patient to be on clozapine and then do the weekly blood draws and then bi-weekly blood draws for up to a year after starting it. So it's clinically useful, but you have to kind of assume that responsibility that we're also doing specialized monitoring. Olanzapine, it looked like it's on this list, but based on the analysis by the MDS panel, that's not efficacious. It's an unacceptable risk. It's not useful. Quetiapine has insufficient evidence according to this guideline, acceptable risk without specialized monitoring, and possibly useful, right? But look at pimavanserin it's efficacious, it's acceptable risk without specialized monitoring, and it's clinically useful. And so these are the recommendations. And so, but when you're making clinical decisions, you have to know all of these guidelines, and that's why it's really important. When a patient of mine has a psychotic experience, I try my best. Let's say they have psychosis as part of their Parkinson's disease psychosis. Let's say, hypothetically, they get a urinary tract infection. And now they've gone from low levels of psychosis to higher levels of psychosis. They end up in the hospital. I do my best to ask them, even if you live 2 hours away, if you can please come to Georgetown, where I know that, I have some say in how to treat you. I can talk to the residents of neurology. I have communication with them. Now I have a social worker that can help us. And so, I feel more comfortable with our patients coming to our hospital because I have more control over educating the people taking care of my patients. I know the nurses on the unit. I know I have a specialized neurology unit that can take care of them. So these sorts of things, in terms of recommendations, can be helpful. But you got it. Using a medicine like Haldol can be dangerous for our Parkinson's patients.
And this is how we end up with more ideas for live streams, because you just gave me another thing thinking we need to talk about, like, if you're not having an immediate, like, I'm having a heart attack, I've got to go to the closest place, or I just had an accident. If you're not having that and you need to go to the emergency room, actually selecting the emergency room that is able to best deal with you is actually a really great tool that we really don't talk about. So now we've got another live stream. There's just endless that we can talk about.
I'm excited.
Yeah, I love that. So somebody put in here a question. Basically what they said is sebum diagnostic research looks promising. Curious if you have any thought about sebum diagnostic research.
I'm unaware. I don't know what that is.
Yeah. Okay.
I'll look it up. I'm not sure.
If you have a further question, and maybe that was just a statement, let me know and I'll read that. I know there was some other ones in here, so let me get down to this. There was a comment about rigidity causing fatigue. And I'm curious, and actually I'm curious too, if you see that as partially potentially impacting falls.
It's a great question. So, right, we said, so how do you diagnose Parkinson's, right? We use the UK brain bank criteria. You don't need a tremor to diagnose Parkinson's. You can have rigidity, stiffness, gait impairment, and slowness of movement. And so rigidity can be part of Parkinson's, and it can cause pain, right? So you can have one stiff leg that causes pain and cramping. We screen for cramping in our patients, and that, again, that's non-specific. How many people have cramping, right? But if you put it all together, you know, and the clinical symptomatology all kind of point towards Parkinson's, and you use that. But rigidity, you know, can cause falling. In particular, dystonia. Dystonia is kind of, it's not so much that cogwheeling like rigidity that we see in Parkinson's. Dystonia is where you have so much tightness in a muscle that you have agonist and antagonist muscles that are stiff and tight, okay? And so, for example, the leg, the foot, you know, you can have conformations of the foot where the foot isn't weak, but it gets stuck in a conformation, a dystonic posture. Or your arm can get stuck to your body like this. It makes it even harder to swing. That's called dystonia. We can have cervical dystonia. The neck can get stuck in this position. That can be part of the high tone in the muscles because of the basal ganglia pathology. And so we can use medicines like botulinum toxin to help relieve the tightness in the neck, for example, cervical dystonia, or the tightness in the leg called limb dystonia. We even see patients that have writer's cramp like dystonia, right? Everyone's heard of writer's cramp when people used to write and not type. Well, maybe we'll see typer's cramp one day. But you see, we do inject muscles of the forearm with Botox or botulinum toxin. There's multiple types of botulinum toxin. And so that's how we try and treat, along with the medicines. The medicines help relieve rigidity, help relieve dystonia, because the rigidity and dystonia is part of Parkinson's. Falling because of dystonia is there. I mean, you can imagine if their neck is stuck like this, you need to be able to react, turn your head so that you don't fall. You need to be able to be more mobile. You can't have stiff muscles or rigidity for falls. The other thing that's important is actually not forgetting, in terms of falls, cognitive function, that frontal lobe function. We'll talk about more frontal lobe function at our next presentation. Sarah, I have that, but because cognition is part of that one as well, screening and everything. But that frontal lobe function is really important. Sometimes cognitive medications can help reduce falling because you're improving people's ability to execute tasks. So it's not all one thing. It's kind of you have a holistic view of our patients.
I love that. That's fantastic. Somebody asked when the next presentation is, and a couple people said they needed to get back to their clinic. So we will make sure that you get the link to this so you can rewatch it, because I think it's full of really great information. The next presentation is in 2 weeks. And as Dr. Torres-Yagi talked about, we're going to talk about cognition and some of the assessments that you can do, some of the ways you can evaluate your patients, especially if you're not seeing them in person. We don't want you to wait to actually treat them. Since Parkinson's doesn't have the pause button, we don't want you to wait to treat them. Dr. Torres-Yagi, it is always a pleasure to spend time with you and spend an hour with you and learn from you. This was such great information, and you can tell just by the questions and engagement. Thank you so much for sharing your time with us and sharing your knowledge with us. It's fantastic. We're so glad that you are practicing in this field.
Oh, you got it. Thank you so much for the invitation. And I really enjoyed, I saw a lot of smiles and nods. And so hopefully it was an informative presentation. And so thank you. And I look forward to our next one. We'll talk about how do we assess patients, as Sarah said, and how do we really clinically, not just diagnose, but monitor, evaluate for all the different things that we talked about today. How do we do it? What do we do in a clinical setting? So thank you so much.
Wonderful. Thank you so much. Everybody have a wonderful weekend, and thank you again, Dr. Torres-Yagi.
You're welcome. Bye-bye. Okay. Have a great weekend.
Thanks. Bye-bye.